Okay, so I gave a listen to my first video, and sounded really good. I mean, I feel like the audio could have been fixed a little bit better. Also, yeah, I really liked when I would just ask, like, oh, what are the 3 rapid ways to reduce hyperkalemia in like an EM setting and emergency setting? And in my head, I was like automatically like throwing out answers. So when a question's asked during this video, it's kind of like pimping. I really like that too. So I might just ask more questions during this. Yeah, let's get through it.
A 29-year-old woman comes to the clinic for evaluation of leakage of urine. For the past week, the patient has had to urinate every hour and has had leakage of urine while trying to run to the bathroom. She has had no hematuria, dysuria, or flank pain. The patient has no chronic medical conditions and has had no surgeries. She has had 2 vaginal deliveries without complications. The patient drinks multiple cups of coffee and diet soda daily. Temperature is 99 F, 37.2 C. Blood pressure is 122/76. mmHg, and pulse is 84/min. BMI is 29 kilograms per meter to the power of 2. On speculum examination, the bladder has no descent, but the patient leaks urine with Valsalva maneuver. Urine dipstick shows protein none, blood negative, glucose negative, ketones negative, leukocyte esterase positive, nitrites. Pregnancy test is negative. Which of the following is the best next step in management of this patient?
Alexa, stop. So I guess she's had 2 vaginal deliveries. That's basically that, but the patient leaks urine with the Valsalva maneuver. So she has like a weakening. I mean, the leukocyte esterase is positive. But I feel like it could be between these 2. She may be. What's the next best step? Okay, so we're not gonna go with the hemoglobin A1C because the glucose was negative. Can't rule out UTI because the leukocyte esterase was positive. I don't know what this would be for, and I really still don't understand the difference between a continence pessary placement and a mid-urethral sling. So I'll just go here. Oh, good for me. Yeah, E. coli. Let's see what urodynamic testing is.
Urodynamic testing is typically reserved for patients who have mixed urinary incontinence, complicated urinary incontinence I, no response to treatment, or are considering surgical intervention.
Okay, so it's a screening for basically surgical intervention.
This patient with leakage of urine also has new onset urinary frequency and urgency, with urinalysis findings suggestive of a urinary tract infection UTI. UTIs are common in women due to the short length of the female urethra and its proximity to the vagina and rectum. Although UTI typically causes dysuria, it may also present with more subtle symptoms, including urgency, egg, running to the bathroom, frequency egg, urinating every hour, and urinary incontinence egg, leakage of urine due to bladder, spasm. Patients with classic UTI symptoms are treated empirically with no additional evaluation. Those, such as this patient, with more subtle symptoms can undergo urine dipstick or urinalysis testing. Patients with UTIs often have positive leukocyte esterase, indicating white blood cells in the bladder due to cystitis. The presence of nitrites is more variable and depends on inoculation time, pathogen type, and urine pH changes. The most common pathogen, Escherichia coli, typically causes positive nitrites. However, less common pathogens, egg, Staphylococcus saprophyticus, and some home remedies egg, cranberry juice can cause a negative nitrite result. Patients with urinary symptoms, egg, urgency, frequency, leakage, and a positive leukocyte esterase are diagnosed with UTI, and first-line treatment is with oral antibiotic therapy, egg, nitrofurantoin, trimethoprim sulfamethoxazole.
That reminds me, right here. One time we were doing like Jeopardy or something like that at one of my rotations. And they were like, oh, what is the most common bug found in like sexually active female for a UTI? And they were like, oh, staph saprophyticus. And I was like, no, 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 it's E. coli. They're like, no, 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 like sexually active female. Now, in a board's question, they may, it depends on how they word it. For example, if they say, what is the most common, what is it called? What is the most common gram positive UTI infection in women that are sexually active? Yeah, it is Staphylococcus saprophyticus. But overall, it's E. coli, hands down. The rotation preceptor was like, yeah, I don't think she's seen like staph saprophyticus like twice or three times in her whole career, but like E. coli is on everyone usually. Oh, I didn't get to learn what these are.
Continence pessaries and midurethral slings treat stress urinary incontinence, which causes leakage of urine with Valsalva maneuver due to urethral hypermobility, associated with bladder descent or intrinsic sphincteric deficiency. This patient's acute onset of symptoms and lack of bladder descent make this diagnosis less likely. Her leakage with Valsalva maneuver is due to bladder irritation exacerbated by increased intra-abdominal pressure.
All right. I really still don't know what that is.
A 56-year-old woman comes to the office due to worsening fatigue and edema of the bilateral lower extremities for the past several months. She also reports that her legs feel tight. The patient has no prior medical conditions and takes no medications. Family history is significant for hypothyroidism in her sister. The patient does not use tobacco, alcohol, or recreational drugs. Temperature is 37 C, 98.6 F. Blood pressure is 112/64 mmHg, and pulse is 86/min and regular. Physical examination reveals normal heart and lung sounds, mild hepatomegaly, and pitting edema of the bilateral lower extremities. Other examination findings are shown in the exhibit. Laboratory studies are as follows.
Bruh, what the fuck? Trying to say she has like what is that? Like an ecchymosis? Fuck if I know. Shit. Okay, so there's some sort of like glomerulonephritis maybe. Let's see. I mean, liver enzymes are fine. I would say she's maybe a little bit anemic. So out of our answers, ooh, maybe. Legs feel tight, edema, hypothyroidism. What's gonna cause hepatomegaly though? I really just don't know here. So what causes proteinuria? Maybe amyloidosis? Oh, let's go. Let's fucking go, bitch. Get fucked. I was gonna say like, I don't know, maybe amyloidosis like is a part of the different renal syndromes and such. Nephrotic, that's what I was looking for. Most commonly presents as nephrotic syndrome. Hepatomegaly, restrictive cardiomyopathy. I'll just have this read out for you. Bitch.
Educational objective. AL amyloidosis most commonly presents as nephrotic syndrome. Hepatomegaly and restrictive cardiomyopathy are other frequent manifestations. Periorbital purpura is a rare but highly characteristic skin finding.
Oh, it's paraorbital purpura. I'll mark that. So basically like low sensitivity, high specificity. I've been doing too many stats problems recently.
This patient with nephrotic syndrome, hepatomegaly, and periorbital purpura likely has AL amyloidosis. The unifying feature of amyloidose, AL, age-related and hereditary amyloidosis, is misfolded precursor proteins that deposit in extracellular tissues as fibrils, causing organ dysfunction. AL amyloidosis results from excess immunoglobulin, light chains produced in plasma cell dyscrasias, multiple myeloma, Waldenstraw macroglobulinemia. Although some overlap exists between the different amyloidoses, the organs involved vary with the type of precursor protein. AL amyloidosis commonly presents with kidney involvement manifesting as nephrotic syndrome, AG4 plus proteinuria, low albumin pitting edema. Also prominent are hepatomegaly and restrictive cardiomyopathy. The deposits can lead to waxy, tight skin epidermal deposits, macroglossia, and peripheral neuropathy. Periorbital purpura is a rare, but very characteristic finding that may reflect protein infiltration causing a bleeding diadactianisis, due to factor X sequestration in the liver, and weakening of vessel walls leading to hemorrhage. Because of potential response to chemotherapy, AL amyloidosis requires differentiation from the other types of systemic amyloidosis. The presence of a clonal plasma cell disorder is confirmed by serum or urine protein electrophoresis, free light chain assay, or bone marrow biopsy.
All right, so this is a statistics question. It's a two-part.
Based on the abstract, which of the following conclusions is most appropriate?
So we need to conclude. Oh, just this abstract.
A 46-year-old woman comes to the office for follow-up of type 2 diabetes mellitus. The patient has been following a standard diabetic diet and the same oral anti-diabetic agent regimen for the past 8 months. BMI is 25.2 kg/m2, waist circumference is 83 centimeters, and hemoglobin A1c, HbA1c, is 7.3%. The patient recently read an article comparing a vegan diet to a standard diabetic diet in control of HbA1c levels. An excerpt from the study abstract is shown.
Vegan, standard. Let's see. Zero and 12 weeks. 0, 12. Okay, so 0 to 12, that's a decrease. Oh, here we go. Oh, these double things are statistically significant. So it's asking for a BMI. It does see that. Yes. Yeah, sure. Yeah, see? The key in this one is to remind yourself, what does this double star mean? And a lot of times the double star is like literally an arrow. It's like, hey, look, I know you saw all this bullshit that I just gave you, but look right here. It's like highlighter and or like a big arrow. Just imagine a big arrow being like, look, 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 this is it. I wonder if it says anything. All right, we'll just move to the next one.
Which of the following recommendations is appropriate for this patient?
Okay. Was there a lot of drop off? I don't know. Yeah. Huh. Well, it depends. What was their starting? Yeah. Yeah, see, they both started with 60, but only 50. Yeah. Yeah. Definitely that one. Wow. I just killed these two fucking stats questions. Nice.
A 76-year-old woman is brought to the hospital due to confusion for the past hour. The patient's husband says she started having an occipital headache 2 hours ago and took acetaminophen and went to bed. An hour later, he had difficulty waking her and found her confused. Medical history is significant for hypertension and seizure disorder.
Stroke.
The patient takes phenytoin amlodipine and lisinopril. She lives with her husband and is independent in her daily activities. Temperature is 37.9 C, 100.2 F. Blood pressure is 170/100 mmHg, and pulse is 70/min and regular. The patient is somnolent but wakes up with painful stimuli and withdraws all four extremities to pain. She is unable to follow simple commands and mumbles a few unintelligible words. Deep tendon reflexes are symmetric, and Babinski sign is absent bilaterally. Fingerstick blood glucose is 110 mg/dl.
Okay, so, she doesn't seem to have had a stroke. I don't think we need to go straight to a lumbar puncture. That seems a little drastic. EEG, I don't think she's having a stroke. With contrast is more detailed. It seems like this is more of an emergency. Confusion. Yeah, I mean, why she take? Oh, a seizure disorder. Could she be having a seizure? Maybe. Yeah, if she's, and then I don't know if an adverse effect of phenytoin is this kind of like, flu-like syndrome, but if she has a seizure disorder, we may want to just rule out that she's having a long-ass seizure. But that, at the same time, doesn't make sense, because why would she be having it for a fucking hour? Serum phenytoin level kind of makes sense, but honestly, CT seems a little drastic. The only thing that I can like argue for it is this and like that. She could be having like a subarachnoid hemorrhage, I guess you could say, in which case a lumbar puncture would be indicated. But like, fucking, yeah. All right, sweet. So concerning for stroke, yeah, okay. Where do I go here?
This patient's acute onset of altered mental status, egg confusion, somnolence, and headache in the setting of hypertension are concerning for stroke. Because the efficacy of stroke treatment, systemic thrombolytics, is time-dependent, i.e., time is brain, a non-contrast CT scan of the head should be performed emergently whenever stroke is suspected. Non-contrast CT scan can rapidly differentiate between hemorrhagic and ischemic stroke. Hemorrhagic stroke hemorrhage is immediately evident as a hyperdense, i.e. white, area within the brain parenchyma. Ischemic stroke, hyperdense hemorrhage is absent. Subtle signs of ischemia, loss of gray-white matter differentiation, hypoattenuation of deep nuclei, may be present, but CT is often normal in early 6 hours. Ischemic stroke. CT scan findings help direct management. For patients with CT scan evidence of hemorrhagic stroke, thrombolytics are contraindicated instead. Blood pressure is controlled, anticoagulation is reversed, when applicable, and neurosurgery is consulted emergently. In contrast, patients without hemorrhage on CT scan are considered to have ischemic stroke and may be candidates for thrombolytic therapy and/or mechanical thrombectomy. In contrast, patients without hemorrhage on CT scan are considered to have ischemic stroke and may be candidates for thrombolytic therapy and/or mechanical thrombectomy. Educational objective. In patients with suspected stroke, non-contrast CT scan of the head should be performed emergently to differentiate hemorrhagic versus ischemic stroke and guide further management. A 19-year-old woman comes to the urgent care center due to increasing pain in her right leg. She initially felt a dull, aching pain at the anterior aspect of the lower leg 4 weeks ago, and it has been getting progressively worse. The patient is an avid dancer and often practices 3 to 4 hours a day. The pain now interferes with dance rehearsals. Medical history is remarkable for irregular, light menstrual periods, for which she is being evaluated by her gynecologist. The patient drinks alcohol only on social occasions and does not smoke or use recreational drugs. Temperature is 36.7 C, 98.1 F, blood pressure is 122/78 mmHg, and pulse is 70/min. BMI is 16 kgm2. Examination shows point tenderness over the anterior aspect of the right shin, 7 centimeters above the ankle joint, which does not change with resisted dorsiflexion of the foot. There are no skin abnormalities, and the rest of the physical examination is unremarkable. X-ray of the lower leg reveals no abnormalities. Which of the following is the most likely diagnosis?
So this is pretty simple stuff.
This patient has subacute leg pain consistent with a tibial stress fracture, which most commonly occurs in athletes, runners, dancers, or other individuals who increase their activity level without adequate rest. These types of fractures are caused by repeated tension or compression and absent recovery periods. They are especially common in women who have low caloric intake and functional hypothalamic amenorrhea, which lowers bone density, low BMI. Other factors contributing to stress fractures include improper footwear, biomechanical abnormalities, weak calf muscles, high arched feet, and inadequate calcium and vitamin D intake. In addition to the tibia, stress fractures can be seen in the metatarsals, tarsal bones, navicular calcaneus, and less commonly the femur and pelvis. Diagnosis is based primarily on clinical factors, including localized activity-related pain and point tenderness on palpation. Swelling may be present. X-ray is frequently normal, especially in the first few weeks, but may reveal periosteal reaction at the fracture site. MRI and bone scan are more sensitive but usually unnecessary, unless a high-risk site is involved. Educational objective. Tibial stress fractures are caused by repeated tension or compression without adequate rest and occur most commonly in athletes or others who suddenly increase their activity level. Findings include subacute, localized activity-related pain, swelling, and point tenderness on palpation. X-ray is frequently normal. A 59-year-old woman comes to the office due to upper respiratory symptoms for 3 days. She arrives an hour late for her appointment and lies about the reason, blaming it on an emergency at work. The patient is angry that the physician refused to prescribe antibiotics for her over the phone, and she paces at the reception desk, insisting that the office staff work her into the schedule because I'm very busy and must be seen immediately. She mentions that her previous physician always made time for her. The patient is a successful businesswoman and is recently divorced. During the visit, she expresses irritation at having to take time out of her busy day to come to the appointment and admits to being under stress at work. The patient then talks at length about feeling depressed because her children no longer want to see her even though she is a great mother. She is upset that her daughter recently canceled plans to visit in order to help a friend who was in a near-fatal motor vehicle collision. The patient has no significant medical history, and family history is notable for major depressive disorder in her mother. Which of the following is the best explanation for this patient's behavior?
fuck, I don't know, but this. I don't know, but like I just felt it. It was this one.
This patient's behavior is characteristic of narcissistic personality disorder, a pervasive pattern of grandiosity, need for admiration, sense of entitlement, and lack of empathy. Although these patients can often be charming and successful, their motivation is to obtain constant attention and praise. Often arrogant and boastful, they display an exaggerated sense of self-importance and frequently overestimate their abilities and accomplishments. These individuals have difficulty sustaining relationships because they are unwilling to recognize or identify with the feelings and needs of others. They are often disappointed in relationships when their needs to be admired and to be the center of attention are not met, as in this patient, who is upset that her daughter chose to help a friend rather than see her. In the medical setting, these patients may be demanding and feel entitled to special treatment, being angry that the physician will not prescribe antibiotics over the phone, insisting on being seen immediately.
Okay, that's it.